Okay, I'm gonna call the meeting to order. We have participants joining, and we have a lot of wonderful content. So I'd like to be on time. I'm Jean Aymon. I'm a liver transplant surgeon and the executive director of the Transplant Center at New York-Presbyterian. We have 9 other wonderful faculty members, both surgeons and physicians, who represent the transplant teams at Columbia and Cornell and the Presbyterian Hospital, representing the solid organs, heart, liver, kidney, as well as bone marrow transplantation. So we have a wonderful program for you, and we've arranged to have some questions that we think are of interest to everybody. And then we'll try to work our way through those questions. And then we should have hopefully about 20 minutes or more at the end for questions from the participants. So welcome everybody. And I'd like to introduce the Medical Director of Intestinal Transplant, Mercedes Martinez, who's been with us for many years, a wonderful, charismatic doctor. Dr. Martinez.
Good evening, everyone. I want to welcome and thanks everyone for taking your time to join us tonight to discuss this important topic of providing optimal care to pediatric transplant recipients in a COVID-safe environment. We want to run a very interactive topic tonight with answering your questions and your concern. To submit your question, use the question and answer function. On the lower part of your screen, you see that function. And also, we are going to try to answer all your questions, but the questions that we are not going to have and we can answer tonight, we are going to compile that and send it to you later. Also, this conference is recorded and will be available at the website. Then this is kind of the housekeeping thing. I'm going to move now to the presentation. I want to start by telling you that it's an extraordinary honor that you trust us with the care of yourself or your children. And in return, the New York-Presbyterian Enterprise is committed to provide state-of-the-art care in the safest possible environment. Then this commitment has been tested to the fullest during the last few months, during the pandemic and the worst pandemic of our life. During the pandemic, you were afraid to come to us, to the hospital, and we were concerned that if you came to the hospital, you might get infected. Still, through innovation and hard work, we changed the way that we practice medicine, and we tried to provide a safe environment to provide that care. We never stopped offering life-saving transplant procedures. Patients were chosen to be the sickest patients, and also those patients that might have an organ offer available. Organ offer was scarce during this time, and not many patients got transplanted, but those patients that needed a transplant received the transplant. We also provide face-to-face care for those patients that were sick and really required that care. But the very innovative efforts that New York-Presbyterian put in place allow us to provide that care in a virtual way with virtual visits, and I think that everybody's satisfied with that care. And we, during the virtual visit, evaluate which patient needed to come, and we took care of those patients. But now that the pandemic is decreasing in our area, and under the guidance of the New York State Department of Health, the hospital leadership assembled a task force to create a hospital-wide program to return to the new normal. Then this is not going to be like before, but it's a new normal. We know that even during the pandemic, virtual visits were excellent. Eventually, we need to see you face to face. We need to examine you. We need to schedule routine procedures that were placed on hold. And for that, we can provide the best care for you as a person and to care for the organ. The hospital have made significant changes to be able to bring you back and to get that care in a COVID-safe environment. Applying what we learned during the pandemic. We learned during the pandemic that the protection works, that social distance is important, and minimize exposure to infected patients is vital. Then based on that, the hospital have expanded the working hours, minimizing crowding in the waiting area. We have extended the time of the appointment. Then you come in, you go to the room, the appointment is complete, and everything we try to do that within the room. You also receive a phone call within 24 or 48 hours before the appointment to see if you have any COVID symptoms or you have been exposed to COVID. And if that is the case, we will assess what is the best way to treat you, bringing you to the clinic or to a different environment. But also the hospital have created something called the COVID Pass, where all the healthcare workers have an easy way to notify the supervisor if they have any symptoms or they have been exposed to COVID, and then they are not coming to work. Then we are protecting you from ourselves the same way that we are protecting from each other. When you come in, you will get a temperature check to make sure that you are not febrile. If you come in without a mask will be provided in the entrance, and then when you get to the areas, the healthcare workers are going to be also using protection. Remember, personal protection work. They are going to be wearing a mask or maybe a facial shield or some kind of eye covering protection. Social distancing is the most important. Then you will see that the waiting rooms might be empty. This is not the kind of environment that you are used to seeing in the hospital. The elevators, there are spots marked in the elevator. We don't want people to get crowded in the elevator area. And there is also something very interesting that happened with Epic, and it's that e-registration option. Most of the paperwork can be complete before you come to the hospital from home. Then when you enter the clinic area, you don't have to spend 20 minutes filling out paperwork. You can go directly to your room, and you will be in your room until the appointment is complete. Hand hygiene is paramount of importance. Then you will be able to practice that everywhere, and the hospital employees are very aware of that. Extensive and frequent cleaning in all the surface between patients is being done. Then when you finish that appointment, you leave the room. This room is going to be clean and will be empty for a few minutes until the next patient comes. When you enter, you will see a sign that says that that room has been through a terminal cleaning. Then I think that all these measures should give you some kind of safety feeling, and also start thinking that it's time to go back to the new normal. We still are going to continue televisit. Those patients that can be cared through televisit or telemedicine, we are going to continue that. But if you need to come for an appointment, if you need to come for a procedure, we want you to feel comfortable and come in without any hesitation. You are more likely to get infected with COVID in the supermarket or in your daily life than you are in the hospital, because in the hospital we are disciplined using the PPE. Maybe some citizens out there are not as disciplined as we are. And now with that, I want to turn back to Dr. Imon and a world-renowned panelist expert to the discussion regarding the measures and other concerns.
Thank you, Mercedes. I'd like to ask our medical director of renal transplant, Namrata Jain, to share a video with one of her wonderful patients.
Thank you so much for the introduction. I'm Namrata Jain. This is actually a shared patient of mine and Linda Adenizio, who is the director of heart transplant. We both work at Columbia together. This video that you're going to see is from a very special patient. His name is Janum. He'll introduce you to himself. I'm sure he's watching now with his family, and I appreciate him doing this video about his experience. But he actually had a heart transplant at 5 years of age here at Columbia. And most recently, he underwent a kidney transplant from his mother, who was a donor. So both had the experience of having a COVID-safe kidney transplant donation, as well as recipient allograft here at Columbia, and it was done on June 11th. So we wanted to just share his experience. He wanted to share his experience as well on how he felt during the experience. So let's see the video. Thank you.
Hi, my name is Janum Shah. I just had a kidney transplant last month. I was in there for 10 days, 3 days pre-op where they did some dialysis, 7 days post-op only. Recovery was pretty easy, and overall the experience was really smooth. For the COVID, for being scared of COVID, it was really pretty safe. I had my own room. Doctors were really sterile. They sanitized and were masks and gloves all the time. And I didn't really feel scared about it at all. Now a month passed, I'm feeling much better, and soon enough I'll be back to normal. Thanks.
That's really a handsome young man. It was a pleasure to see how well he did. Just think about it. He's only a month after surgery. He looks like he's ready to go anywhere. So that's gratifying, and that's the experience we'd like to you all to expect. Now, with respect to surgery, I'd like to introduce a few of our surgeons to tell you a little bit about their perspective. First is Ardavan Akavan, who's a professor of urologic surgery. He's a robotic expert, and he's going to talk a little bit about these type of major procedures.
Hi, thank you so much. This is Ardavan Akavan. I'm one of the pediatric urologists. We've been working closely with our transplant team for years, and we have now ramped up our process, and now we're offering full services in the hospital. With regards to how we interact with the transplant team patients, preoperatively, we're specifically used to evaluate bladders to make sure that the bladders are safe for kids to get kidney transplants. And so that involves doing uroflowmetry or urodynamics. We have our own urodynamics suite and uroflowmetry suite, and these are fully functional right now. When it comes to the surgeries that we perform on our transplant patients, they include upper tract surgeries like nephrectomies, removing kidneys sometimes becomes necessary before the transplantation. Additionally, bladder reconstructions, urinary diversions like bladder augmentation, Mitrofanov, bladder neck reconstructions for after the transplant. These we are also performing once again. Additionally, we're removing ureteral stents in kids who've had stents placed during their transplantations. We're taking several precautions to make sure that these are done as safely as possible. The first is that most of our visits and interactions with patients are going to be virtual. To date, about 95% of all of our visits are now through telemedicine, so you don't have to actually come into the hospital. You can actually just speak with us virtually. Additionally, when you do have to come into the hospital, we're advocating a lot of patient distancing, such that you won't see another patient in a waiting room. All of the patients who come in, they'll be distanced out, both time-wise and physically, such that you'll have your own room. And if you are in a waiting room, you'll be the only family in the waiting room. In terms of, I'm seeing a question, what is being done to enforce and educate in COVID?
Let's deal with those questions a little later.
Oh, excuse me, I'm sorry.
Oh, it's okay.
Sure. In terms of sterilizing in between patients, so all the rooms and all the facilities, all of the equipment that we use when we see patients either for procedures or for visits are all sterilized in between patients. And if you have to come in for surgery, the pre-op area that we're invoking a lot of distancing in the waiting areas, both for families and for the patients, so that you're not within, I think it's about at least 6 feet, but we're actually seeing it's much further with other families. Additionally, we're invoking strict mask and PPE policies in the hospital, in the operating room, in the clinics, in the elevators, in the PACUs, and in the ORs especially. And also, if your procedure does involve an inpatient stay, all the rooms will be private rooms as well, and there'll be strict only need to enter policies in the rooms. There will only be one parent allowed in the room at the time as well, just to minimize the number of people entering and exiting. So I'll go over some questions. What is being done to enforce and educate COVID policies in-house? It's become a culture, I would say, in the hospital over the last few weeks, such that everyone is just policing each other. If you see someone without a mask or with their mask on exposing a nose, usually 5 or 6 people come up to them pretty quickly and tell them to modify their behavior. It's just become part of the routine expectation. We have so much self-policing, and we have so much literature all around the hospital that it's rare to encounter any violations. So it's being enforced, and the education standards are really all over the hospital.
Thank you very much. I'd like to ask Adam Griesemer to talk about live donation in liver transplantation.
Thank you. I don't think there's another team that's as focused on patient safety as our living donor teams, because we're taking care of patients who have nothing wrong with them and are trying to help another human being by donating part of their body to them as an organ transplant. And so our team did ramp down during the early phase of COVID, and we are now fully ramped back up. We have made some adjustments to try to minimize the risks to our donors. Our evaluations now utilize virtual visits, telemedicine, to limit the number of contacts that potential donors have until we have identified that they are indeed good candidates for donation. And then we bring them into the hospital to complete their testing and to get physical exams that we require before we do surgery on any patient. To date, we have performed multiple living donor liver transplants. We have taken up to 70% of donor livers out safely, and the patients have recovered very well and returned back home within 4 to 5 days following the donation. For pediatric recipients, it is our custom to take 15 to 20% of the donor liver, because that's the appropriate size for most of our pediatric recipients. So we actually think the risk to the donor is much less for a pediatric recipient than it is for an adult recipient. And one of the other reasons that we are really trying to focus on pediatric living donor liver transplant and renal transplant is the waiting times are decreased if our recipients get living donors. So the health of the recipient is optimal going into the transplant surgery. So the recovery of the recipient is faster. So they are in the hospital less, they are exposed to that environment for a shorter amount of time, and we can get them home much faster. If their health is good going into the operating room, their health is good coming out of the operating room. So we think it really offers an optimal situation for the recipients, and we do it in a safe way for the donors as well.
Thank you very much. I'd like to ask Dr. Linda Adenizio, who's been at Columbia forever. We are so lucky to have her. She's the medical director of heart transplantation. I'd like to ask Linda to comment on the ongoing diagnostic procedures that are required to survey a patient after transplant.
Yes, thank you, John. I also would like to say that during COVID, we of course couldn't stop doing heart transplants in children, so that during this period we've done 8 pediatric heart transplants and 4 ventricular assist devices, because when children are sick, the hospital always rises to the occasion and takes care of those children. Now, in terms of when the children come back to the hospital for outpatient visits or outpatient catheterizations, we're really trying to do the one-stop shopping, where everything gets done in one room as best as possible. So for instance, when a child needs a catheterization, we try and get their echocardiogram done in the catheterization recovery room area and their EKG, and our doctors actually go to them to examine them there. Similarly, in the clinic, they come in and they're placed in one room, and we'll get all their testing done as well as their exam, so that then they can go directly home. So we have tried as much as possible to keep children and families from being exposed to anybody else.
Thank you, that's wonderful. Dr. Satwani is the director of the bone marrow transplant program, another group of patients who require exquisite care. Do you want to comment on how you're handling post-transplant surveillance in this time?
So based on COVID pandemic, we have to make some changes to our practice. However, even during the height of pandemic, we continue to do bone marrow transplants. And because many of the transplants were done for patients who had cancer. So what we do differently now is that we collect the bone marrow from the donors, which could be parent or sibling, 2 weeks before we start to give chemotherapy to the patient, so that in case donor gets sick, we already have a bone marrow product to infuse. So that is one major change we have done, and which is, I think, very safe practice for the patients, because after they get high-dose chemotherapy, they must get bone marrow infusion. So that safety is in place for all the patients, and we'll continue to do that. Now, in terms of clinic follow-up, majority of the patients who are fresh from bone marrow transplant, they were required to come to the clinic, and our clinic has changed drastically. We are seeing around 30% of our patients in terms of capacity. And as Dr. Martinez said earlier, elevators are dedicated for our patients. And when they come off the elevators, they directly go to the room, and we try to do everything in the room so that they don't have to go in and out. And we are minimizing the number of people coming into the room for patients. So that's a one step we have taken. And those patients who are far from transplant, we are doing a lot of televisits, and that has worked very well for many of the patients, as many of our transplants patients were from Queens, and parents were very scared to come to the hospital because Queens was hit hard. So, I think there are several steps, as Dr. Martinez alluded earlier, has been taken for our immunocompromised bone marrow transplant patient, as well as patients who are undergoing cancer chemotherapy. So I believe our environment is very safe, and patients and parents should feel comfortable coming to our clinic or the hospital for bone marrow transplant.
Thank you so much. I'd like to shift a little bit so we can stay to time. Dr. Labrito, can you tell us a little bit about how transplant patients have done in terms of recovery if they do get the virus?
Certainly, thank you, Dr. Iman. For the most part, transplant patients have fared quite well. Dr. Martinez and I were charged with creating a national COVID registry for both liver transplant recipients and chronic liver disease patients. So interestingly, the vast majority of patients were asymptomatic or had minor symptoms. Only about 25% of the liver transplant patients required admission to the hospital. The chronic liver patients did a little worse, with about 75% being admitted, but only a small fraction of those being admitted to the ICU. All of the transplant patients have recovered. There was one death among the chronic liver patients. We think it's probably a function of comorbidities, the degree of liver failure at the time that they got sick, diabetes, obesity, renal issues, similar to what we see in the adult data. But for the transplant patients, we feel that immunosuppression actually might be somewhat protective, though it's not been proven. The exaggerated inflammatory response to the COVID infection that occurs 7 to 10 days in, leading to a lot of the pulmonary symptoms and some of the systemic symptoms, doesn't seem to happen with the same frequency in transplant patients. And certainly we're glad about that, but we're still, the lesson to be learned is that anyone can get sick from COVID, and that prevention is key.
Thank you so much. Juhi Kumar is the medical director of kidney transplant on the Cornell campus. Could you comment on what you've observed in the kidney transplant patients who encounter the virus?
Certainly, thank you, Dr. Iman. So talking from the perspective of our kidney transplant recipients, most of them have done very well. In talking to colleagues across the country and in looking at whatever has been published so far out of Europe, very few children got COVID-19 and very few needed hospitalization, and even less than 1% needed ICU care or needed ventilatory support. Some children developed acute kidney injury in that their creatinine rose, and that was very likely related to being dehydrated and not getting enough fluids. So, but the kidney function came back to baseline after they were treated with IV fluids and the acute illness resolved. The most common symptoms that was reported were fever, cough, runny nose, and diarrhea in most of the patients. We have been very fortunate that our kidney transplant recipients have not fallen very sick with the COVID-19 illness, but that should not lull us into a false sense of security. We need to still continue to practice social distancing, wear masks, do the hand washing, and stay away from crowds. And also, we should not be taking any symptom such as fever or any symptom that is suggestive of COVID lightly. Anytime your child has such a symptom, you should definitely contact your transplant physician.
Thank you. I'd like to ask Dr. Cato. He is our surgical division chief of organ transplantation. He's a world famous intestinal and multivisceral transplant surgeon. I'd like to ask Dr. Cato to comment on what patients should expect in terms of the preparation for surgery.
Okay, thanks for the introduction. We are fully back operational in any type of surgery. We're pretty much back to normal. So if you need any surgery, not necessarily transplant surgery, something else, the transplant patient needed a surgery, we just do the surgery as we used to. The only difference is that you have to be tested for COVID at least 2 days prior, but no more than 5 days prior. So meaning that you have to get the test between 5 days before till 2 days before in that window. If you don't get tested, there's a chance that your procedure may be delayed or postponed. So just make sure that you work with the doctors to make sure that you get tested prior to procedure within this window of 5 and 2 days prior to procedure. Another thing is that if you need an emergent surgery, something that you need to have a surgery for emergency reason, we have a capability to test you for the rapid PCR. So the rapid PCR will turn around much faster, so we can still get the result of that PCR before going into the operating room. That also protects you, but as well as us, the healthcare workers. And then transplant-wise, if you are living donor transplant, both recipient and the donors will be tested prior to procedure in the same window. And if you are cadaveric transplant coding for organ offer, first of all, the cadaveric donors are all tested for COVID. So we know that donor has negative COVID test prior to proceed with transplant, and the recipient will also have the rapid test. So those are the procedure that you need to be aware of.
Thank you very much. Now we have a lot of interest from the audience about how we manage immunosuppression, but I'd like to ask Dr. Adonisio to comment on what happens if your child gets a fever. What do you do?
Well, thank you. So many people have asked, if my child gets a fever, should I bring them to the emergency room right away? And the answer is not necessarily. The most important thing for transplant patients is that you should call your transplant provider and allow them to help, make a contingency plan on when or if your child needs to come to the emergency room. Perhaps they'll schedule a video visit. Perhaps they'll have you see the local pediatrician. But in this era of COVID, it is important to speak to your transplant provider because many of common childhood illnesses have similar symptoms to COVID. So that's what we would suggest. So you don't necessarily have to bring them right away, but contact your transplant provider.
Dr. Satwani, would you give similar advice?
As we all know, patients post-bone marrow transplant are much more immunocompromised and they have central lines. So our policy would be that if you have a fever, please contact your transplant team. And it's very likely that you will be asked to come to emergency room if you have a fresh bone marrow transplant or have a central line. And, we always tell our patients, when you come to emergency room, please come prepared to get admitted. So same advice, even in the COVID pandemic era, that all the fevers within first 6 months post bone marrow transplant require emergency room visit, and very highly likely that they will be admitted to the hospital for further care. So our philosophy is very different than what Linda said because of the difference in degree of immunosuppression and the whole host of complications our patients have post-bone marrow transplant.
I think it's fair to say that if patients are stable long-term after an organ transplant, you can manage them more like a healthy person. And we'll talk about immunosuppression in a bit. I'd like to ask Dr. Martinez to comment on the kind of testing that we use to diagnose and manage the COVID, the coronavirus.
Thank you again, Dr. Ramon. Then, as Dr. Keto was saying, when patients come to the hospital for a procedure or for any admission, they might get tested with a PCR. Then the PCR detects the virus, and this is the best method to diagnose whether you are infected or not. And this is, for now on, is just an esopharyngeal swab that is going to be sent to the lab. There are different methods, and the hospital used 2 or 3 different methods to do this test. The rapid is the one that is used for emergencies, for procedures and admission. And the other PCR, the result, the turnaround time is about 7 or 8 hours. It doesn't take a week for us to know if somebody have COVID or not. Then this is the test that is done to diagnose if you are infected or not. Then the antibody test that many people ask about, should we get the antibody test? Then the antibody test will tell you that you have been exposed to the virus and that you have developed antibodies to the virus. Many people are very enthusiastic about this test because they think if I have antibody, I might not get infected again. And we don't know enough about this test yet to think that way. I really think that we still should be cautious. Even if you are positive for antibody, that means that you have been exposed. That doesn't mean that you have immunity. Eventually, I think that over time, we might learn that certain level of antibody can confer immunity, but we don't know that yet. Then these are basically the 2 major tests. There is another test that is called the antigen test. That is not very readily available and is not used in most clinical settings. Then just not to confuse people, I will not talk about that. Then it's basically PCR for the diagnosis, antibodies that determine that you have been exposed, but don't give you immunity. It might, but we don't know for how long, then don't count on that.
The scientists here at Columbia, Dr. David Ho and his team have discovered that patients make hundreds of different antibodies when they're sick with COVID, and not all of them are protective. So the tests we are getting now at the standard laboratories may not reflect the full spectrum of immunity. While I have Dr. Martinez on, could you comment about the vaccine situation?
Then vaccines, everybody's excited about vaccines. We really think that this might change our life in the future, maybe going back to normality. There are maybe about 130 vaccines that has been now in the making. There are about maybe 15 to 20 that are good, promising vaccines. Some of those vaccines, 3 or 4, are already in advanced phases of clinical trial, phase 2, phase 3. Everybody has been hearing the news this week. We start phase 3 and vaccinating about 30,000 people here in the United States. Then this is very exciting time. These vaccines development has been extremely rapid and extremely fast. And one question that I get from the patient is it safe? If we usually take 5 or 10 years to develop a vaccine and test for the safety of this vaccine, are these vaccines safe and should we give them to our patient? Then the reality is that we are not compromising the safety. The testing for the safety is being done. What we are doing is maybe expending money. Usually it takes, the phase 1 takes few years or few months, and until we analyze all the data, we will not move to phase 2, and then it takes few years between each phase, and then the production start. I think that many entrepreneurs and the government has put a lot of money to start the production, even when these vaccines are in early phases. And I think that this is why the development of these vaccines is going faster, but I don't think that the safety of the vaccines is compromised by any means.
Dr. Jane, so just to finish the conversation about the vaccines, what will you be recommending to the transplant patients when the vaccines are available? And we may have more than one to choose from.
So I think that's a great question. Thank you, Dr. Mon and Dr. Martinez. So I think this is a question, and I saw one of the family members had asked this. Is this going to be safe when one of these vaccines is available to give to a child who has had either bone marrow transplant, heart transplant, kidney, or liver? To be honest with you, even as we're going into the phase 3 with the 30,000 recipients who are trying out the vaccines, I still want to give it more time to see how this vaccine is doing, what the side effects are on patients who have normal or immune competency. And that's important because, as you guys know, you are all scared to, and we'll go into further discussions about, you know, bringing your children out into the community and schools. Is it going to be safe to get this vaccine? And I think that I actually am not having my patients, even when the vaccines are coming out, jump and get that vaccine because we don't know that much about it. We won't know how efficacious it is, how long it's going to last. Do you need to check levels to see after a few months, is it still present? What is that testing going to look like as well? So I think at this moment, at least for pediatric kidney transplant, we are not having everybody jump in on the vaccine wagon once it comes out, because I'd like to see a little bit more long-term data. So I think the social distancing and the wearing masks, and as you all have been protecting your children as much as possible who are immunosuppressed, I think that will be the safest course than just jumping onto a new vaccine, even however exciting it might be, until we have more information.
The vaccines that will be available are made in different ways. The old-fashioned vaccines are made from viruses that are inactivated or neutralized, and we've been cautious in the past about vaccinating transplant patients with inactivated or live viruses that are weakened. So now there are other vaccines that are being made by new methods that have not really ever been tried in a large scale, using pieces of protein or pieces of DNA or RNA. Those might be safer, but they're also less proven. So I think there will be, I think we all agree, we're gonna have to be a little cautious at the beginning until we see how the vaccines perform in large numbers of healthy people. I'd like to ask, we've been getting a lot of questions about how we manage immunosuppression. Dr. Kumar, could you talk a little bit about how you would approach immunosuppression if the patient gets, a transplant patient gets coronavirus?
Thank you, Dr. Ahmad. Certainly I can comment on that. So I would preface this answer by saying that any change to immunosuppression has to be patient specific and done under guidance of your transplant physician. So it will depend on a number of factors, whether you decrease the immunosuppression or not. It will depend on the severity of your COVID illness, how sick you are from your COVID. It will depend on any underlying condition you might have, such as asthma or diabetes, along with your organ transplant. And then other potential factors that affect the functioning of your transplant might also be taken into consideration when making that decision. In the literature that has been published so far, and in talking to other colleagues, most kidney transplant recipients had very mild symptoms and were managed at home, and no changes were made to their immunosuppression medications. Some of those who were hospitalized and were sick enough had some decreases made in the doses of their medications, and the most likely medication that was reduced was MMF or Celsep, also known as mycophenolate. So that was the most common change that was made. Again, to reiterate that it will be patient specific and depend on a number of factors and should not be done on your own. It should always be under the direction of your transplant physician. And again, if changes are made to immunosuppression medication, you will need to be monitored more closely, and the frequency and the kind of monitoring will be decided by your transplant physician, so that we can also make sure that your kidney transplant or any other organ transplant is continuing to do well.
Dr. Labrito, do you mind adding your perspective about immunosuppression?
So I agree that, you know, in the beginning, we all felt very nervous about immunosuppression, and we sort of tried to dramatically reduce immunosuppression to improve outcomes. And what happened is we precipitated some rejections as a consequence. So I think that modest reductions, usually in the antimetabolite, the mycophenolate mofetil, is probably warranted, that steroids and tacrolimus in the vast majority of cases do not need to be reduced. And I think it's a balance, and it should be guided by the patient's current condition, comorbidities, complications of the transplant. It's not a one-size-fits-all and should be individualized.
Great, thank you. Dr. Adenizio, do you want to add anything about immunosuppression?
Yes, I agree with both of the previous answers. We need to individualize it for the child, just like sometimes with certain viral infections, their white blood cell counts may be very low, and we might temporarily stop the CellCept or modify something. But in general, our children with heart transplants who have gotten COVID, we have not changed their immunosuppression unless pushed by a lab value.
Good. There's an interesting question here that maybe we should talk about. Children who get the coronavirus, can it affect the solid organs? And have we seen this? I can answer for the liver. In fact, coronavirus does infect the liver. And sometimes it's a mixture between rejection and corona hepatitis. And we've actually been able to treat that successfully. Dr. Martinez has managed such a case. We have another one actually right now in an adult patient. Have you seen any heart inflammation from coronavirus?
So not in our transplant patients. It's something we look for. There was a recent study that came out in adults that showed that all the patients that they didn't think had any problems with their hearts after a COVID infection did subsequently on MRI show some scar and things. So I think we don't know completely, but there are ways when we're following our patients that we can look to see if there's heart damage. But in general, at least our transplant patients have not had a lot of heart muscle infection.
A lot of the organ damage from coronavirus is caused by inflammation. Dr. Griesemer, do you want to comment on that relationship between inflammation and rejection and COVID medical management?
Yeah, it's a difficult decision when you see the coronavirus affecting the organ. When we saw it affecting the liver in one of our recipients and they had COVID hepatitis, when we weaned the immunosuppression, then the patient developed a mild rejection that then had to be treated. And inflammation is a nonspecific signal to the immune system. It can be triggered by a response to a virus, but it can have side effects of drawing the attention of the immune system to the organ that is transplanted and precipitating a rejection. So it can be a fine line to walk about how much immunosuppression to use. One of the possibilities is that the steroids that are often used to manage immunosuppression can actually tamp down the inflammation. And it may be one of the more important drugs to use in those situations to calm down the response both to the virus and limit the off-site targets, or the side effects of activating the immune system that can precipitate rejection.
So there's a question here about whether transplant patients should be tested for antibodies. In fact, we were just looking at the data. We're getting ready to publish probably the first big paper on this. The transplant patients who develop the antibodies tend to lose them after a couple months. In fact, regular people lose their antibodies too. We're not quite sure how fast they come up or how fast they go away. And we're definitely not sure whether they're protective. So for the time being, it's, if we get an antibody test back that's positive, it does not in any way guarantee that the patient will be able to go out in public without protection. So until we learn more about this, And frankly, until we have a vaccine that works reliably, the antibody is probably not good enough by itself to know that your child is safe. So I'm gonna move now to the million-dollar, multi-million-dollar question that everybody has is, what about sending your kids to school? I think those of us who are, I'm a grandparent, and I'm sure a lot of our group are parents, and a lot of our patients' parents want to know what we think. So I'd like to ask Dr. Jain to start with her perspective on school, actually next month or this month. What do you advise your families?
So honestly, this is a great question. And like you said, this is a multi-million-dollar question. And I don't think there's one good answer. Just as treatments for our patients who may have COVID can be different and case by case, it's also case by case for your child as well. To be honest, for my kids that we're preparing for transplant imminently, we're going to be doing another transplant. We have done 2 COVID-safe transplants, one last week and one in June. We have another one this month coming up. I'm not having those children go to day camps in school because I don't want them to get sick so that we would have to push off push off the transplant. That being said, prior to COVID and the pandemic, we did not recommend that our children go to school for 2 months afterwards. Now in the setting of COVID, especially since a lot of the medications that we give to these children to decrease their immune system to accept the kidney transplant, I know for myself and Dr. Adenizio, usually the first 6 months is the highest risk of rejection, as well as your immune system is the lowest. So I'm very hesitant to have those kids who just had a recent transplant or those who had a rejection. So now we have to further lower their immune system, or those who have other risk factors, such as diabetes and obesity or lung concerns. Those are the ones that I'm more hesitant to send back to school. Again, there are other children and families who need to decide on amongst themselves if they've been 5-10 years out of kidney transplant. That might be the only option for these families, so that parents can also go to work. It's a very tough time for everybody. And we all know for children, as we're all pediatricians, they learn through play and socialization, and it's hard to do to Zoom. And I have 2 young kids. It's hard to get a pre-Ker and a 2-year-old to listen to the person. They just want to push the buttons and turn down the computer and turn off everything. So I understand it's really, really hard. But I think really the first 6 months after a transplant and right before we're planning your transplant date is the time I'm most hesitant to send someone out into the school environment. But I know this is an answer that doesn't have a right answer and a universal answer for everybody. So I'm interested also to hear from Dr. Adenizio and Dr. Satwani with their thoughts for this as well.
Dr. Satwani, do you want to go next?
Sure, John. Thank you, Namrata. So I think this is probably the most challenging question, and I'm not sure about the multi-million. I think it's definitely probably the most difficult question. We all have been pondering how to safely answer this question. So in bone marrow transplant patient, obviously we don't send them to school with or without COVID issues for first 6 months. So for our patients, that's pretty much going to school is out of question. The second is after 6 months, if patients are doing well, their immunosuppression is at a low level, they're not having any major complication from transplant, we do let them go to school. Now, in the COVID pandemic era, I believe the best thing will be to do a remote learning. And after a year post-transplant, I will feel safe to send patients to go to school. And the one comforting thing we have noticed in bone marrow transplant patients who have gotten infected with COVID is that they are either asymptomatic or they have mild symptoms. And it's a kind of counterintuitive that patients who are immunocompromised are not getting as sick as the patients who have healthy immune system. So, this virus obviously triggers a massive immune response in some patients. We haven't seen that in bone marrow transplant patients. So God forbid somebody does catch COVID when they go to school. I am pretty hopeful that we can manage them safely and many of them will not get symptoms. So here post bone marrow transplant, I think patients should go to school, but prior to that, it has to be discussed pros and cons of going to school.
Linda?
Okay, well, I sort of look at it this way. I mean, our heart transplant patients pre-COVID would be able to go back to school at 3 months after transplant unless they were being treated for rejection or something more serious. However, if everybody can remember pre-pandemic, children used to go to school sick every day. And I think that school systems in the tri-state area and around the country are trying to find a better way to protect the children. And whether it be alternating classes or some home learning, some in-class room learning. But I think that there are certain things that you can work with your school. I think children who are many years out after transplant, maybe they could go to school, but they have to wear masks all the time. Except when they're eating, and they can't eat in large cafeterias, and they need small classes. So really the best time for them to go to school is once we have a vaccine that has been tested. And so I think for the next year, school is going to be less of a place where we want to send a lot of transplant children than depending on what the school systems come up with. But I wouldn't be opposed for some children who are very far out, who are old enough to practice social distancing and to wear masks to be able to go to school.
So we got a very interesting question. I wonder if Dr. Martinez would tackle it, about indoor athletic dance or performance classes. What do you think about that?
Then I think that indoor is like the classroom. I saw also some questions about church and any indoor activity is very similar. You can be there if you are practicing social distancing, and dance, you might be to be very close. You need to be very close with another person. And then it comes the mask. We get exposed, we interact with people every day, and if we cannot keep the social distancing, we can wear the mask, and that will help. One of the questions I saw, they said, what happens if the other people are not wearing masks? Then I think that if the person is going to go to that activity, everybody should wear masks, unless the person wear a very tight N95 that is very uncomfortable, even for us. We wear it for several hours doing procedures and in the hospital when we take care of COVID patients, but I'm not sure that a child can endure that, wearing the mask and be comfortable with that. Then I really think that all indoor activities are similar to school, and unless you practice social distancing or everybody's wearing a mask, you shouldn't go.
Unfortunately, the athletic exercise activities, and actually the worst one is choir and singing, produce a lot of aerosol. And so the masks that most people wear on the street are primarily to limit the amount of distance that the particles and the droplets go. And like Dr. Martinez said, the only masks that is truly safe are the really high density N95 respirators that we use in the hospital. But you can't have a dance class or sing or do cardio wearing an N95. It's just impossible. So I think those kind of activities indoors are going to be a problem for the time being. And if your transplant child is the only one wearing a mask, they probably won't have enough protection unless they're wearing an N95, at which point it's not likely they're going to want to be doing cardio. So that's a challenging questions. Yeah, this is another great question. For those who have many children, if you have a transplant child and you're keeping them home, but your other kids go to school, what advice do you have for the parents? Linda?
I was kind of hoping you wouldn't notice me here. So it is a very difficult question. It was difficult in the height of the pandemic when transplant families were having other children coming home from college. You know, where do they go? Do they need to be on lockdown somewhere else? So I think we can kind of think about it the same way we would if there was an infection in the household. So that, you know, the siblings should wear a mask at school, good hand washing. When they come into the house, they should change their clothes, take a shower, and shouldn't be using, you know, the same towels, cups, plates, you know, as the transplant child. I think in this day and age, it's getting harder to socially distance them completely within a house, especially for some of our families who don't have a lot of space. So that's what I would recommend to try and keep them safe.
Yeah, I think that's fair. Anybody else want to tackle that? Namrata?
I agree with that answer as well. I think that, you know, as we were talking about what to do with your own transplant kit, many of you have more than one child and blessed as such in that way. And I think that they should be able to go to school. But again, the social distancing and mask wearing. And I feel like from many of my transplant families, they are more police-like about this with their siblings, and their siblings are so protective of the actual child who has the transplant. They have no intention for harm. And so I think that what coronavirus, with all this that we're going through with the pandemic, we've seen, you know, families really bond to protect that transplant child as if they're a newborn. And I usually tell my parents when they just have a new transplant, I was like, this is your newborn for the next few months. And they're like, oh, I get it. And so, you know, and then the siblings tend to treat similarly. So I do feel that sibling families are trying their best to take care of their own, you know, sibling respectively. But I do encourage them to go to school if they're able to in a safe environment in their school districts, as many are going hybrid, so that they have an option to, you know, actually come home and maybe teach their siblings something that they learned in person, so that they can have that interaction that is important for the transplant child.
Yeah, I wanted to comment. So I learned something yesterday from an infectious disease professor from Harvard, who it's been observed that the incidence of a lot of other common viruses has gone down, way down during the pandemic. And I think it was Dr. Adonisio who mentioned that, you know, typically we all go to work when we're sick. People send their kids to school when they're sick before COVID. And I think one of the factors here is that everybody's being a lot more careful. So other common viruses are not being spread as effectively because of the precautions people are taking for corona. There may be other reasons for that, but it's a surprising finding. So does anybody know about the ultraviolet sanitizing systems? I definitely don't know anything about it. There's a question about that here.
One of the professor at Columbia, Dr. David Brenner, he is one of the pioneer in this kind of technology, and he was in New York Times recently talking about this technique, which is going to be probably used in subways and hospitals where they can sanitize very effectively with ultraviolet rays. So I think people are looking into that.
You know, I think something Dr. Martinez said earlier in the beginning, when we were not wearing precautions, in the first 2 weeks of March, a lot of our doctors and nurses got sick. And as soon as we started wearing masks, even though there were literally thousands of corona patients in our system, people stopped getting sick among our healthcare workers. So I'm pretty sure that, and I'm not a scientist here, but I'm pretty sure that the most, if not all of the exposure occurs when you're in a close environment, breathing on each other or talking at each other, and that there's very little transmission from physical objects. That doesn't mean you can't be clean, but breathing, breathing, breathing is how this thing spreads. And that's our biggest challenge and biggest precaution.
John, and I'd just like to add that the other precaution is the fact that so many people are getting the virus from people who are asymptomatic. So it's those asymptomatic carriers who are before they're getting sick that can be spreading. So don't think that just because someone's not sick that they might not have the virus, because there's a period of time before they get sick where they can spread the virus. So that's why we keep trying to say, wear your mask, use your Purell, and wash your hands. I mean, that's the best thing that we can do, I think.
Well, the only thing I would add to that, Jean, is that I do think there's a potential to get this from surfaces, and that I think that anything that's frequently touched, like telephones, remote controls, or anything along those lines, handles of. So I think you need to be careful. And since the virus can be introduced through the eyes, the nose, and the mouth, that while wearing a mask, you should not frequently adjust your mask, touching your face, frequently without at least washing your hands in between. So I think there is some transmission that way. Clearly, respiratory is primary.
Good. So we're near the end of, well, we're at the end of our hour. I think we've had an amazing conversation that handled both the science as well as the hospital care and the most important thing about real life out there in the world. Are there anything that any of our faculty want to add to the discussion? It's been a wonderful discussion.
I think one of the things that was highlighted is every recipient is a little different. If you have questions about your specific patient or loved one in your family, reach out to your provider. We do televisits. We can do these things without having to bring you in and do them very safely. We're dedicated to keeping everyone safe while providing the best medical care possible that we feel in the country. So we are here for you, and we will answer any questions you have.
Well, thank you. In closing, I'd say it's a privilege for all of us to take care of your children and your families. And it's a privilege for me to have these amazing doctors on our team and for me to be able to hang out with them. So thank you, everybody, and have a wonderful evening.
Thank you very much, John, for hosting. Thank you, Mercedes. And, thank you.
Thanks,
Have a
everybody.
good night.
Thank you. It was very nice.
Okay. Good night.
Night.